This conference will now be recorded.
Hi everyone, good afternoon. Welcome you all to the expert talk on interoperability. And today's topic is interoperability, global challenges and opportunities. And this talk will be by the panel of experts from Philips Interoperability Solutions Group. So we have with us Abhijeet. He is the sales enablement leader at Health Informatics, Philips. Suju Krishnan is the delivery manager for EIS, and Deb is solution architect for the Interoperability Solutions Group. So with this, I hand over the controls to Abhijeet to get started. Over to you, Abhijeet.
Thank you, Satyam, for having us here. Good evening, everyone. Good afternoon, if you're in a different time zone. So the way we'll go about it is maybe a quick round of introduction from all of us speakers, and then we hit on to the topic. The format would be around 30 minutes of sharing what we have to share, and then we would love to, have a dedicated Q&A session as well. Yeah. So my name is Abhijeet Landge. I've been with Philips for the last 3 years, and in healthcare informatics as a domain for the last 20 plus years. So started off as a developer, did multiple things, wrote tons of code, took my own code and took it to customers. Version control was a nightmare. So was interoperability. Yeah, that was my first brush with multiple systems, devices, solutions, not talking to each other, and so on. Fate took me to multiple geographies and markets, and everything I think was a learning experience. And the last 2.5, 3 years in Philips, I've been looking at how do we adopt a solutions approach, and incidentally looking at core problems of healthcare in terms of improving health outcomes, the patient experience, and so on. Well, that's about me. Let me hand it over to Suju.
Thanks a lot, Abhijeet. Good evening, everybody. Thanks a lot for joining us in this session. My name is Suju Krishnan. I am part of the Interoperability Solutions team in Philips. And from a career perspective, I started off my journey as an engineer in the year 2000. And so far, most of it, almost 17 plus years, has been in healthcare IT on the software side. From 2011 onwards, I'm working as part of the Philips healthcare systems, working out of the Bangalore office. I have been associated with a product in Philips called as Philips IntelliBridge Enterprise. I have been the project manager for that for almost 5 years. In the last 2 years, I've been focusing on pre-sales and delivery, and because of which I have got a chance to look at interoperability, a little more of a broader view of interoperability across various different geographies, and how the needs are and how they can be addressed. That's a bit about me. I would now transfer it to Debabrata Parida from RT.
Thank you, Suju. Yeah, hi everybody. Good afternoon or good evening based on the locations you are connecting from outside. This is Debrat. Again, the healthcare journey started way back in 2000 for me, starting with different organizations, basically the lab vendors, EMR vendors, and then now in Philips, predominantly into interoperability world from the last decades and more. And yeah, so today I go around to different geographies and then look into the interoperability challenges that they have, different kind of solutions that is there. That is something that I do apart from program managing a set of software engineers as well. So that's me. Thank you. I think we can get started.
Yeah, over to you, Abhijeet.
Yeah, thanks, DB. Yeah, so if we can move to the next slide, I think this is something that really depicts what interoperability solutions achieve, right? They build bridges, they connect systems and devices. And it's not an easy journey. So if you look at what are we enabling out here, it's all about data, it's all about information. And collaboration, I think, is the key. We need to look at aligning workflows, clinical, non-clinical, administrative, billing, financial, payers. The kind of stakeholders are enormous within healthcare. However, we have seen and noticed, and I'm sure many of you would recognize that healthcare as an industry has lagged behind other industries. So if you take BFSI or you take a few others, and it's not just a function of appropriate technology, yeah, but it's also about stakeholders, hospitals being owned by governments, profit, not for profit, regulations, data privacy, and a host of other things. But I think with the increasing focus on how do you improve outcomes, you are moving from paper, maybe a fee or a service, to something which is outcome based, outcome driven. How do you improve patient experience? How do you improve staff satisfaction? How do you reduce physician burnout? So these are kind of key elements, obviously driving up efficiencies, reducing the cost. These are a couple of key elements that we all would love to engage with. And that's something which we are very passionate about. And it's not easy. So this schematic of a diagram that you see on your screens right now talks about the varied complexity of the solutions involved. It's got clinical aspects, it's got patient management, ambulatory care, inpatient cares, and so on. And there's a strong tendency towards optimizing solutions. And then there's that debate on best of breed versus best of suite. Which option do we take, and so on? How do I extract more money or more buck from my legacy system? And obviously, implementing a solution from scratch or ground up is such a pain. Yeah, it's a nightmare. So there are multiple aspects to it, multiple dimensions. And if you look at customer needs, obviously, healthcare professionals want to have access to relevant information about their patients. We are moving towards preventive care. You have EHR records and multiple systems. You have healthcare organizations who are supported by other ones like payers. You have insurance companies. IT departments have their own set of needs in terms of maybe safe, simple, secure, keeping malware outside, and multitude of stakeholders, right? So we can just go on and on about it, but the point that I'm trying to make here is just to drive home the complexity of the situation. Yeah. And I think with this, let me hand it over to Suju, who would walk you through a specific case as well.
Yes, thanks a lot, Abhijeet. Dave, if you could move to the next slide, please. Yes, so we are the complexity of the healthcare sector, the backend, the infrastructure was mentioned by Abhijeet in the last slide. Let me turn the focus away from that and look at the patient. Obviously, the patient is not sure about this complexity. He is here in the hospital so that one of his needs is met. Jim arrives in the hospital, basically ER, with a chest pain. He goes through a bunch of procedures. Patient information is generated, ECG is generated, imaging exams are done, and we have a report created for Jim, and that is basically looked at by a doctor, the attending physician. He receives that report, and within that report, basically there is medical history, medications, previous examinations, and all other kind of information. Jim has to now visit a cardiologist, and since the cardiologist is a specialist, there are again a bunch of reports, right? And when you look at the longitudinal and holistic view of care, it means that this care cycle is not the only cycle that the patient will have. He will be probably taken to a tertiary hospital, or he'll be taken to another care setting where the care has to be monitored. from a patient's point of view, in a patient-centric healthcare system, the most important thing for the patient is that the care happens continuously and seamlessly. And the complexity of healthcare is hidden behind the walls of the healthcare system, and a seamless and promising experience is given to the patient, and the physician has to be given maximum possible help in this regard. And that is where the complexity of healthcare gives way to the reason why we need to have interoperable systems. Dave, if you could go to the next slide, please. DB?
Looks like Dave has a network problem. So please continue, Suju.
Okay. So the next slide was basically related to the fact that I mean, I'll have to talk this through now since DB is not able to show the slide. But let me just take a step back and explain it. Oh, yeah, I can see that
there,
come up on screen. Yeah, thank you very much, DB. So this is the context which we want to say, right? If you look at interoperability, we start off with small devices which are connected to the patient. It could be a bunch of monitoring systems which are on the bed, which are called as bedside monitors. It could be some kind of a view in the nursing station where a bunch of such patients are getting their consolidated aggregated view to the master at the nursing station. It could be something to do with home healthcare. It could be healthcare within an enterprise setting, various different departments of a hospital ensuring that the patient information is communicated through and through. And finally, it could be, as we were discussing in the previous slide, moving from one care setting to the other and seamless flow of information. So what we are seeing here is that information ranging from very discrete information, which is more real-time in nature, and the other information which is more longitudinal. All these things have to come together so that interoperability can be given to the patient. So if we could move to the next slide, please. So in effect, what we have is that we will have siloed systems and we will have a lot of redundant tasks, and more than anything else, we will have patients suffering if we don't have true interoperability. So what we have told till now is that there is obviously the urgent need to have interoperable systems. We need to break the silos and move forward. And the next slide here, Dave, if you can take me there, throws up those various different challenges which we as the community need to address. This is for all of us in this discussion today. We need to ask ourselves whether our systems of record, can they communicate to each other? Are they available in various different care settings? Do we have sufficient workflows? And how do we ensure that there is continuous flow of information no matter what the care setting is? So this is basically the challenge which we are throwing to the audience, and this is the topic that we want to discuss a little more further. With that, I would like to hand it over to Debabrata to continue with how we are addressing this challenge.
So maybe Suju, just to add before we hand it over to Dave, because he would get in a very program manager and a architect's view. So we are essentially looking at multiple types of interoperability, right? So it's connected devices, connected systems, and with mobile phones and changing form factors, we're also looking at connected services. So in effect, leading to connected healthcare, whether it's a single standalone hospital, a primary healthcare center, or a large complex multi-entity chain of hospitals, right?
Yes, that is right. This is the problem and this is the challenge. We are having various different digital systems across the continuum of care which needs to be connected. And the digital transformation for the hospitals can happen only when these silos are broken.
Yep. Thank you, Suju, for giving me at this juncture. So as we all know, like today's healthcare is no more going to a hospital and get treated. It is no more a critical care. It's also something called preventive care. It is also something to be being healthy, and it's a multidimensional, right? So in that, if you we call that as a health continuum. So it starts from cradle to grave is a kind of scenario that we are talking now in this platform. So all of this while we have multiple of devices into the picture, multiple of products or applications that needs to push in data to understand a specific patient. We need to have a complete holistic figure to understand, okay, what is that is required for a specific patient, and we're slowly moving towards person specific treatments and so on and so forth. So for all of these that to make it happen, like we had all the different departments. We had emergency rooms, theaters, all connected into one single hospital, and we had interoperability confined to that space. And then the situation got complex when we had IDNs and they were a network. They wanted to solve the same problem across their network, and they didn't want to replicate the the same model or same set of systems across, rather optimize their systems and also give a better care, because one hospital might be specialized in cardiology and the other hospital might be specialized in cancer. And when a patient moves across the hospital, they wanted the data to be seamlessly moving across. They wanted the patient reports moving across, and so on and so forth. The so complexity become a double fold there. And now we are talking about situation where the state is interested in all the health data, and a lot of places, a lot of governments across the world have started creating their database or a registry for all the people of their country. So basically, all the citizens. They have separate health record IDs, which they do it. They collect, and then there are a lot of data that flows across from these IDNs of the hospitals back to the government based on certain needs. The latest example might be, the COVID situations where government knows that, okay, how many patients came in every day, how many got tested, how many got positive, how many, got cured, and things of this data, so that the data can be consolidated at a national level where the decision and the policies can be made. And that's one part of it. There are a lot of governments across the world who has gone beyond just a policy making to alert services, to do more detailed syndromic surveillances. So there are government who knew there are certain situations should happen, like in the areas of UAE, dust storm is very common. So they wanted to prevent people from getting infected lungs and other things like that. And they started managing the health data along with the geographical data to come out with kind of alert service, which they can push it to the people. So that's how the things got more and more complex. And with that, the interoperability become complex. So this is just a snapshot of how we wanted to do, and still we cater to all the segments of the healthcare in continuum. So basically, you have the touch points or the devices where those are the devices which connect to the patient either at the bedside or in a healthy living kind of situation, that can be your Fitbit device or any kind of wearable devices that transmit your health record to a central pool. But then there comes a new challenge, like how to identify specific people around different systems. There are a lot of EMPI or MPI kind of situation systems available to help us on that. Then there are situations where you collected all of this data. Now what to do with the data? So there are a lot of policy making, lot of business value that can be generated out of these data that gets accumulated on the server or the cloud, so that the processing can be done. Starting from we would go more details on these things in our case studies. We have a couple of case studies to showcase as well, how the interoperability can solve bigger problems than it was thought of earlier. So with
Thank
that,
you.
Just
Thanks.
to add,
Go ahead,
sorry,
Abhijeet.
sir.
yeah, go ahead.
Yeah, so just to add, and put things in context, even if you look at the government specific and health informatics landscape, they've got around 20 different systems, right? Right from district health systems to vaccine distribution management to case tracking to e-hospitals to e-Sushrut to right from reproductive and child health and a host of other things, including individual state governments have their own set of solutions. And that's where, when DB mentioned about a EMPI program, or how do you uniquely identify a patient, a mother, a child, and so on, right? So that's the key point that we are trying to drive home. And this is something that exists across the world. We are not alone in this. But that's just to share and make everyone understand the gravity of the situation. Thank you, Satyam.
Thanks, Abhijeet. So, thanks for the discussion so far. So, few terms that I just wanted to rephrase and just let me know if those terms are right. So, IDN is Integrated Delivery Network, and is that what it is?
Yes, it's like a group of hospitals.
Uh-huh. So, group of hospitals coming together to share data or to manage patient population. Is that what it is?
Indeed.
Okay. Yeah. So, in summary, what I understand is interoperability is about making systems talk to each other, exchange data, because data is critical. Data is life-saving, right? As you mentioned, as Dave mentioned, from
Yes.
cradle to what was the other one?
Grave.
Grave, or womb to tomb, right? So data is important and the data follows you, right? And we are generating lots and lots of data. If that data can all be coming together, and then on that, lot of analytics and other things, business insights and even health insights can be generated, right? So that's the importance of interoperability and seamless data exchange. Understood. So our question next is, how is Philips into this, and what is Philips seeing across the world? If you can highlight some of those through your case studies. I hope those are in the case studies.
Yes and no, both, because we are trying to have the case studies which are highly inspired by the Philips, whatever Philips is doing across the globe on these lines. But for specific reason, we have ignored the exact examples that we are, taking here. So, shall I then go jump to the case studies?
Yeah, sure. If there are any questions to the panel, please put it in the chat. At the appropriate time, I'll ask those questions. Go ahead, Deb, with the case studies.
Okay, so this is basically one case study where we are current situation as well. Okay, now it came, right?
Yeah, it's the Rainbow Hospital.
Yes, so it's actually a hypothetical name that has been given for proprietary, but yes. So the whole idea here is, how complex the interoperability is.
We lost you. If you can hear, if you can switch to a different network, that would be better. In the meanwhile, while Dave comes back, this COVID and the pandemic and the surveillance, right, has spurred the need of data exchange. The government wants to see like what's happening, right? How do I get data? And as Abhijeet mentioned, like, so there are like 22 systems, district level and all, right? And those things are a real challenge for government to get the data, right? So Abhijeet, do you have any further insights into this, right? How this is panning out and what are the challenges coming out here while DB comes online?
Yeah, indeed, Satyam. So I think it's a very pertinent question, whether we have a pandemic at hand or not. And it always, it's always pays to stay prepared for sure, but it's easier said than done. So the whole point being, when you look at, let's say, multiple systems, the underlying framework or the architecture for that is essence. Yeah. So how do you ensure systems are interoperable? What are the APIs that you expose? What are the handlers that you stay open and so on? But I think DB is back. Let me touch upon this at a later point. DB, you're back?
Yes. You're able to hear me now?
Yes, very clear.
Okay. So what I was saying is this is a kind of situation that we can, foresee at what is happening today. And this is, as we speak, is also inspired from some of the work that Philips has done. So what has happened here is, there is the interoperability that comes into picture when we want to get all the data that is available into different hospitals, then from IDNs to from different districts to states to the center level and back. We also know that how many cases have come in, how many people have diagnosed with the positive results of this pandemic or infectious disease, and how where it and all it is spreading. So basically today we can create a heat map and always put it into the map and showcase that okay, which state requires more attention and where we don't need to require attention, where we are people have infrastructure ready, like whether it's a ventilator or your ICU beds, and where it is not available. And if government has procured, let's say, 1 million doses of specific medicine, then where to prioritize, where to send it, basically based on the priority that we can do. And all of this can be done behind the scene with the same set of data that we have in the hospital, that basically flows through the hospital network, and then that gets collected onto the top and to the state level. So that's the beauty of the data that we have been dealing with for decades without realizing that it can be really beneficial when it comes to situation like this. So so that's why I wanted to put this as one of the case study. And the second one would be slightly different, based back to another situation where the state level situations are basically again depicted, but not in a pandemic kind of situation, but a infrastructure level interoperability, where the meaningful data, the value can be given from different source of data. So in the bottom line, if you see, we have all the sources of the data, whether it's a hospital, home care system, our pharmaceutical systems, insurance, payers, and then we have the populations on the left top, which talks about all my health data, which is non-critical, non-clinical data, whether based on my health journey, basically the preventive care part of it. But sometimes this data also has data from the home care system, people who are outside the hospital and then they are still getting treated, those kind of situations as well. So all of this data again can be put into analytics, where we generate a meaningful reason why some data is required, decisions on policies like what we have. I'm just missing that the policy of the Indian policy for the health, Satyam.
Yeah, in the NDHB and the Ayushman Bharat specific.
Yes, so Ayushman Bharat specific items, right? So on those kind of policies, but this is again inspired by another place where Philips has gone ahead and done the um, uh, basically the interoperability part of it, so that similar policies can be decided, because for to have an insurance, you need a lot of data that has to go, get into the system to understand what should be the cost for each healthcare, and basically the cost of health, and then based on that, the insurance companies can come back and give you a proposal on that, and you start making your policies as well. So all of these, if you see, is starts from a very simple, the low layer in the screen, where it is the hundreds of interfaces that we create, from the lab devices to the EMRs, devices from the pharmacy to the EMR, so that a test can be connected to a medicine, can be connected to a allergy, and can be used in the diagnosis. That is the lowest level of interoperability that we do. And then beyond that, it goes into across different data sources or facilities, and then it goes up. So interoperability, as we see, is a journey. It's a biggest journey, and not a single a solution can actually fix all the problems. Rather, a collaboration of lot of systems, lot of interoperability should be there to close the gap. So any questions on these two case studies?
So there are a few questions, DB, in the chat. May I ask now, or do you have any more case studies?
No, we had two.
Okay.
Yeah.
Okay. So I'll go ahead with the questions. Thanks, DB, for explaining. So there is a question: is IDN and HIE same or similar setup? Is it the synonym or they are different?
Well, let me first take a shot at it, and then go ahead,
Okay.
Giri.
No, okay. So basically, IDN, see, HIE is a as we put it, right? It's a system that we talk about, where the healthcare information is exchanged across. But IDN is a physical entity where a group of hospitals, they might not have implemented HIE today, but there's still a group of hospital where they deliver care as a group. They can be there are situations where it is part of the same Apollo group kind of situation, but there are situations where there are multiple different vendors come together to create a network. So it can be either of it, but that's a network that is available today. It's a physical body that is there, and they might have HIE which is implemented, or they might be still operating in a different way. Anything?
Thanks, Abhijeet, you want to add anything?
Yeah, I think indeed DV did cover it. I was just trying to say that an IDN is also a set of hospitals, even if it's not under one single umbrella. They may have formal, informal agreements to share certain KPIs, to share knowledge, to share protocols of nursing care, for example. So these are collectively then called as IDNs. Yeah.
Thanks, Abhijeet. Moving on to the next question, and this is from Praveen. One of the main roadblocks is privacy protection of patients' health data to safeguard patients' health data. What is your thought process on patient consent process for enabling complete data interoperability? Suju, Abhijeet,
Absolutely.
DB? Yeah, go ahead.
Okay. Yeah. So absolutely, Praveen. The privacy is the foremost roadblock that we have in interoperability world. Though there are a lot of efforts that is going on in this world. There are a lot of different ways as well. Like we can talk about anonymization, de-anonymization kind of data. There are a lot of lobbies that happening in US as well to have a consent management system properly in place so that the patient gives consent of specific data. So we need to have a system as well which manages this consent. So we have done some work on those lines as well, where we have put the full-fledged consent management solutions where the consent of a patient is taken for a specific set of data that they want to expose or share, and then based on that you go ahead and build your interoperability. Otherwise all these hospitals or healthcare providers, they have put terabytes of data which is unused because of the privacy and consent.
Okay. If you don't mind, I have a follow-up question. I think the case studies that you ran through, couple of questions there, maybe one question. I didn't see a solution for master data management. Can you just maybe explain how, in those two case studies, how did you implement kind of patient identification?
So patient identification is something that I think I just touched upon. Is like we have, if you, as I told you, right? So there are piece of proprietary pieces that I removed from that. So Philips has a MDM solution where basically it's not a complete EMPI kind of solution that we have. We depend still on that is rather than trying to put everything into one place. Once the IDs are uniquely defined, we have our own CDR systems, as well as we have database where we can put all this patient data. So that's how we uniquely identify the patients across.
Okay, thank you.
Thank you, DB. Moving on to the next question. How is the data collected from fragmented facilities? Do the facilities have some common data entry application?
That's yeah, good.
Suju here. That's a challenge which we are in. I would say the digital transformation of the hospital has to happen. I mean, we can go at this two ways. We can go top down, or we can go bottom up. If we look at it in terms of the various different fragmented systems which are working on proprietary protocols, it calls for the management to move towards standards, right? It is the only way we can bridge the gap, or they have to move away from the proprietary system and at least have an integration engine in the midst, right? If there's an integration in the midst, it will take care of the complexity, it will do the heavy lifting, and you can bring the information from these fragmented systems together. I understand also from a hospital point of view that the already the investment is already made, right? The hospitals have already made big investments into a lot of systems, and unless and until those systems go end of life, it's not very prudent to upgrade them just for interoperability sake. But as part of the digital transformation journey, the way we approach it is we would go in a phase-wise manner, identify the systems which are at least, I mean, I would say if something is on a serial port, you bring it to a TCP/IP connection. If something is not connected to any network and it is like hooked and kept in some place, you just look at an option to at least get it connected to a network. So this is the journey which we will have to go through because the benefits is large, right? If we look at it from an overall perspective, the hospitals gains a lot of efficiency when their systems are getting connected, and they can also bring in cost reductions because of it, and more than anything else, the satisfaction of the staff and the patients at heart will go up significantly.
Thank you, Suju. That was a question from Pooja.
Yeah.
Moving
So
on to
just
the
to
next
add,
question.
before we
please.
move, just add one more. So if this question is specific to the use cases that we showcased here, right? So there are the use cases where the government is involved and they're actually funding. So there are a lot of attractive models that government wanted to put it so that people adhere to these kind of newly developed systems, and they're the system that gets developed. As we speak, a lot of countries actually are trying to develop these kind of smaller systems where they can connect individual fragmented hub facilities to push their data in some way to up. So that work is going on. It's basically a government-driven on the use cases that we are showing, but from the other hand, it requires innovative solutions. Yes.
So that's an interesting take. So, and this is my question to the panel. Do you think a government-backed interoperability initiative of connecting the systems would be more efficient and fruitful than private players coming together and do things? Like, what is the driver? What will be the driver for adoption, country-wise adoption?
Yeah. So Satyam, I think there are multiple. It's a straightforward question, to ask, but there are multiple dimensions. I'm sure you also realize the gravity of it. So if I look at it, what we are trying to also achieve with the National Digital Health Blueprint, right? The kind of consultation meetings that have happened so far, and the document that's come out. It's clearly recognized by the government agencies that interoperability is a very low-hanging fruit, and it definitely needs the right space under the sun, so-called proverbially. To go granular and to go specific, I think we definitely need to identify multiple systems, arrive at a minimum data set, work with insurance companies as well, and obviously with hospitals. And if you were to ask me, does government need to do it by itself? I think they should take the lead. They should set guidelines. They should provide options for private players, private providers to select and follow. And I strongly feel there should be an incentive as well. An incentive is not necessarily monetary incentive, but by ways of some concessions, improve data quality, data hygiene, and the sorts. So I think that's my 60-second view on your question.
Yeah, in the incentive front, just to add, Abhijeet. So if we just flashback, right, when US wanted to clean up the paper-based system to electronic record system, right? So they incentivized all these healthcare providers, and they brought in the regulations as well. So they gave a couple of years, and today at least, almost all of the systems have been moved to digital. So similarly, to push certain things for a larger benefit or a future benefit. If government sees actually the clear benefit that or value that can be churned out of this interoperability, right? So that requires regulations that has to come in, and as well as not only stick in one side, you have to put a carrot in the other side as well. So you have to have incentivize the people who are following it as well, so that it can happen.
Yeah, incentive and penalty. Yeah, DB.
Yes. So
Yep.
thanks, DB and Abhijeet. So there are few questions which are related to like how do you achieve interoperability? What are the things needs to be taken care of? How do you do device interoperability? How do you take care of patient data? So is there a product portfolio or a solution portfolio that you can showcase or show like these are the products and these take care of these specific things, or you can talk about that if you have something in Philips? So the question is, how do you enable interoperability? What are the toolkits? What are the things that you do? So
Yeah, nothing that we had actually ready for that. So it's not there in the deck. So if there are specific questions about, let's say, from Glenn, it was about medical devices.
yes.
And
So what
many
is
other, right? So one of
what is medical
so
device?
one of the
Other is population health. I'll just read out: medical device, population health, then de-identification, then security. So these are 4 questions related to that.
Okay. Good set of questions. I'm happy to answer all of these. So basically, there are 2 ways, right? One is, if I go by chaos theory, so to have everything, everybody going in on the way, and then we'll try to solve the problem. But today's world, we don't have that much of time and patience, right? So what we have to do is we have to bring in standards, and we have to adhere to standards if you have to, basically move faster compared to all other places. So there are standards for medical devices like ASTM and HL7. There are many medical devices that are still operating on the proprietary mode. So that's where the difficulty or roadblocks are. So as long as if we can move them or create a solution, there are solutions, but if we can create more scalable solutions which can convert those proprietary to either HL7 or ASTM, that solves my purpose, because then my integrations become easy. I have one interoperability solution which can talk to the devices, which can talk to applications, and the same interoperability engine I can do, which can spit out the fire, or it can actually talk to a cross document sharing kind of systems, XDAs, or similar to that. So a lot of things, there are a lot of possibilities that can happen. In the top section, basically, if we are talking about population health, cross document sharing, or within the applications, things are more or less standard. So it is that way we can actually cross the river. Once we go down towards the devices, medical devices, that's little proprietary as we speak today. But many of these device companies are moving to either a middleware solution which will spit out HL7, or they are themselves moving out, going towards HL7. So once we have these kind of things, it would help a lot. And there are devices in the digital world as well, medical devices. So there are a lot of standards which can be followed, because as long as we have a standard, interoperability is easy. So more is we have to incentivize the standard. And then the security piece, that's a complete world, different world altogether. So that is not a single.
A related question. What is your take on blockchain in interoperability?
To answer that question, we did try a lot of these solutions, blockchain, in the interoperability world, with some there's a good amount of success, but it's more of return on investment that that's where today things are getting stuck. Otherwise, if we solve that specific puzzle, I think that can be a very good solution. Yes.
Okay. Thank you. So we talked about challenges and opportunities. So one question, and this is from a business angle, right? Why would somebody invest in interoperability, and what is for the companies and the startups to do interoperability for? Because at the end of the day, I sell my product, I get the money, right? Then
Yeah.
where is the incentive for me to do interoperability, and why should I care?
Yeah, the world is actually moving away from those kind of models. Yeah, just to answer the question. So basically, that is
Maybe I
what.
can answer this. Sorry, maybe I can answer this question. See, today, like many of the companies, right, they provide solutions from end to end. Let's take an example of monitoring solution. That right from the leads and the monitor and all the equipment as well as the software that is required is supplied by a single vendor. So with interoperability, what we can achieve is like we can achieve like intra-vendor communication when we achieve, right? So you can bring in a monitoring solution from a software from a different company, and if the device is compatible with FHIR, and if the monitor is capable of reading FHIR and plotting a waveform, so maybe it can, like, you can buy a software which is better from a different vendor and still work with the device that another vendor is providing. So with the, I think I gave some picture about interoperability. Does it make sense?
It does.
Yes, it
Thank you,
does.
Gautam.
Yeah.
Yeah. So more questions?
So the other pieces that I wanted to add, Satyam, here is, uh, the market. It is very difficult in today's market to actually have a differentiating factor. Like if you want to get a differentiation along with your competitors, because so many players in there, right? So it is very easy if there is a single product that you are selling, because it will be replicated very fast. So the more value comes from not a single box that you sold it to someone, as Gautam told nicely. It's more on the value that you generate out of the whole ecosystem, right? And that's where your interoperability will come into picture, because the whole data, as I showcased the first case study, right? So the first case study, it was the same data that is flowing through the systems, hospital, all the while. But the value that gave now, that actually can be a big time business for a lot of startups who don't have to get into the small details of what is happening in my lab, blood analyzer, but I still can solve a bigger problem of COVID, right? So that's what is the value that you can bring in, because the data flows through your system.
Yeah, DB, and just to add on the viability aspect that Satyam mentioned, right? So I think it's a less of a question of viability, but more of a question of guidelines and willingness of stakeholders who own that data, whether it's government, private sector, and so on. So viability, I don't see that to be a major issue in terms of financial viability, but system guidelines and standards viability is a bigger problem to solve.
Thanks, Abhijeet. On a similar note, I did a LinkedIn survey like 2 weeks ago or 2 or 3 weeks ago, and that was my question: like, what are the barriers to interoperability? And the number one barrier was administrative and regulatory. And financial was surprisingly the it was the lowest in the concern that people had raised, right? And even technology was not a big concern in the survey respondent. It was responded by over 100 people, right? So it's
Yeah,
actually
see,
what you said. It's
all of us are here,
administrative.
right? Yes. All of us are here, right? So we can
Uh-huh.
solve any problem that we throw it in the technically. The problem is not there.
Right. Yeah, thanks, DB. So we will take one more question, and this is quite, and it's a disadvantage, right? So this is how Hardik puts it. I was thinking of a disadvantage of interoperability. In some countries where pre-existing diseases are accounted while calculating premium, and if payers are able to collect members' data from providers where members hide their data, then the premium will increase and affordability will be reduced. Please share your thoughts. So the point is, while data sharing is good, it has its own disadvantages.
Yeah. So
Satyam. So it's an interesting question and an interesting
yes, yes.
perspective.
So data all the time.
Yeah, go ahead, DB, go ahead.
Yeah, go ahead, Abhijeet. No. Actually, I was just trying to, tell one simple thing. See, data when we are sharing, right? It need not be always a PHI data that we need to share to get all the values. We have seen, values coming out of non-PHI data as well. Just to figure out how many, let's say, people are there in the country who are above 60 years. And if I have to provide them insurance. So I don't
we
need
can
people.
we can categorize them as volumetric data.
Yes. So de-identified data basically. So we can do anonymization of all this and then push it to for research and analytics, because analytics doesn't care about a person's name, sex or gender, and then they can be identified, right? Fine.
Thanks, TV. So,
Yeah,
we
just
are.
one
Yeah, go
more
ahead.
perspective. Just want to share. This is Praveen here. I think there is also a concept of data validity, right? Like, for example, insurance companies, if they collect certain data, like for example, if the patient is a smoker or the patient has some pre-existing conditions, there is a validity of that data. So they will ask that question again, and if they need to confirm it with lab tests, they will do it. So there is no question of hiding it. They might hide it for probably a 6-month or 1 year period, but still they have to disclose it at some point when they go through lab tests and stuff like that.
That's right.
So you say that do whatever, you can't hide the data, right? So it's better to share the data. That's what
Yeah,
the point you're making,
I mean,
right?
yeah,
Yeah.
I had a personal experience where I had to basically attest again for a smoking cessation test, even though I had answered it earlier as no, whatever. So
Okay, got it. So we are at the top of the hour. It's 7 p.m. So I'll ask my panelists to give final takeaways for the audience, starting with you, Suju. Your 1 minute takeaway for the audience.
Thanks a lot, Satyam. So my takeaway for the audience is that the interoperability journey has just reached a cusp from where this is going to go miles, right? We are at the cusp of a new revolution as far as this is concerned. If you look at the larger scheme of things, if you look at the way, let us even just take the current situation of COVID, the way countries are trying to manage the health of its population, the way you are getting big data, analytics, machine learning, and all these capabilities into the picture. And we all know the data is as good as the data collected. So even if you don't have interoperability at the smallest of layers, you are collecting the wrong data, you are making the wrong projection, you're solving the wrong problem. So it is becoming very, very evident that we need to have interoperable systems. We will have new economies based on this, and the existing economies will grow multifold. That is the projections I can give, and we all are in it, and this is for the benefit of everybody. That's my take on this. Thank you.
Thank you, Suju. Abhijeet.
Hey, thank you, Satyam. So I think in addition to what Suju mentioned, I think I would really urge, the audience to focus on the key drivers. How do you increase adoption of EHR? There's tremendous, focus on reducing costs and increasing the focus on personalized care. Why repeat a test? if you can get the right set of values from one system, another hospital, and so on. And there are increasing avenues as well, where large and diverse set of organizations are wanting to share data. So I think it's a start of an exciting journey. That's how I would look at it.
Thank you, Abhijeet. Deb, your take?
Yeah, for me, I see a lot of values in once we have shared the data across, or there is a proper interoperable systems in place. It's like no one alone can win this battle, right? So if we have to win and make money, everyone, then probably we have to spend time and effort and money onto interoperability, because we have seen, and situation and market have shown us across the globe that what they thought would work without interoperability is next to impossible, because the more and more the earth becomes smaller because of the digitization, we need more and more interoperable solutions.
Thank you, Devi. So thanks everyone for attending today's session. Thank you, Abhijeet, Suju, and Deb for this session. And with this, we close today's session and also the pre-Connectathon webinar series that we had. So we close that as well. Thank you everyone for joining today, and see you all in the Connectathon. Thank you.
Thank you
Thank
very
you.
much.
All the
Thanks,
best.
Satyam.
Bye.
Bye.